I would like to introduce you to Professor Wouter Vanderplasschen. I'm very happy, Wouter, that you could do the effort. You're just back from the EFTC conference from yesterday evening, and we just heard last week that Professor Bryce de Reuver could not participate because he had to present his report for the reformation of the police in Limburg yesterday, so he had no time to prepare anything else. And Wouter was so good to bring a presentation for us on a bright new topic that could be very interesting also in our organization on prevention. Professor Wouter Vanderplasschen is professor at the group of orthopedagogics in Ghent, and he has a lot of experience in research in the field of drug addiction and also prevention, and he was also working in getting a better quality for some programs and some approaches in that field. So he's really somebody who can bring us in depth in some of the researches he did. Professor Vanderplasschen, the word is for you.
Dames en heren, goedemorgen. Bonjour, mesdames et messieurs. Good morning, ladies and gentlemen. I was asked to do this presentation in English, so I will do that if you don't mind. First, I would like to apologize my colleague Bryce de Reuver, who is in another department, who is in criminology, so my approach is more pedagogical, psychological approach, but we collaborate on a lot of projects, so we get along well, and so that was also the reason why I was willing to do this presentation instead of him. The presentation will be on the role of recovery, and I would like to tell you why I think this is a very important topic, because we have long been looking at prevention, at treatment, to really to ban all drug use, but we know that a lot of people start using drugs, and treatment can really make a difference. But we do not so much with the capital we gain from organizing prevention, from organizing treatment, because there is people who recover from substance use after following drug-free treatment. So these people can be of particular use in prevention activities, in treatment activities. So my first point I want to make is that there is a lot of anecdotal and clinical evidence that recovered users make a difference in alcohol and drug prevention and treatment. We know that already for 60, 70 years, because AA, the Alcoholics Anonymous, Narcotics Anonymous, the group that was established for like heroin users, and also, I also have to apologize, I had to bunch this presentation together yesterday evening, so there is some typos, so it's not CO, but CA, which means Cocaine Anonymous, so also for cocaine users there is like self-help groups in which people who have stopped using cocaine, who come together and help each other. As you all know, Johan Martens was before director of the Sleutel, which among others has a drug-free therapeutic community. So in this drug-free environments, role models, ex-drug users are used for, as a kind of social learning model, as an identification model, in order to show the right example, let's say, to younger persons just entering treatment. So there's a very strong evidence for the importance of peer support, of mutual help in this kind of treatment and also in prevention. We all know, I guess, that it's much more for young people, it's much more inspiring to see and to hear the story of someone who has been through addiction and who has been through treatment and who is in recovery, to hear this life story and how it all happened and how he or she could survive this problem. This is a very strong prevention effort, and much stronger than, for instance, put there a policeman who, and we know that this kind of prevention doesn't really work. A policeman with all kinds of products who shows them and says, you can't do this. No, I think this model can be very strong as a prevention and also in treatment, but I'll come to that later. It's a bit striking to see that very few treatment services, prevention services make use of recovered users. So my thesis for this presentation a bit is that there is an underutilization of the strong potential we have there in this service. So my question is a bit, how can we do better? But I'll first go with you through some present-day addiction and recovery concepts, and then we come to the recovery movement. So addiction, whether it is alcohol, drug, or even gambling addiction, it is diagnosed as an individual problem, but it causes various social implications. And we all know the impact on public health, on social cohesion, on safety in society, on employment, and so on. And for long, it has been approached as really as a dichotomy, whether you could abstain from drugs or you continued using. And I think there should be place for other concepts. But the traditional concept has been approach of dependence as an acute disease, like you have maybe a liver or a kidney problem. It has been long approached as an acute condition where a short, sometimes longer, interventions were used to reduce the symptoms, so to take away the drug use in order to achieve an abstinent lifestyle. But we know that it is very challenging and that people often relapse when they have gone through treatment. So recovery is not something that you reach at one moment and then it stays there for all the time. No, it's rather a balance, a vulnerable equilibrium in which people sometimes relapse, but I think at that moment it will be very important to get them as soon back to treatment and to continue the care that they were already receiving. So in this perspective, abstinence is really seen as the way to cure from addiction. And abstinence is very important, but I think people can also recover through other means. So Professor Wim van den Brink is a Dutch psychiatrist who is a very famous name in this field, and he has been describing addiction recently as a chronic relapsing brain disorder. So brain imaging studies have shown that indeed the brain plays a very important role, and in some people they're much more vulnerable to start using drugs and also to continue using drugs, while others do not. And there we in fact also come back to the old AA model, but I'll explain that in a minute. So that has caused that while we, for instance, in the beginning of the 70s, when drug treatment started here in Belgium, when prevention started, we looked at total abstinence, at preventing people from starting using drugs, that we now know many people, many young people, more than half, come in contact with, for instance, cannabis and experiment with it. But it's more important to give them the tools to cope with these substances in the right way, and to give this also a place in their lives. So the focus has shifted from cure to more care, to control and stabilizing the problem. This slide shows some of the models, because addiction science, it's not an exact science, and there is many theories, and I have summed up here, or I based this on an article by Wim van den Brink, but there is at least 6 or 7 theories on addiction, why people become addicted, and some of these theories are still very actual. For instance, you have the moral model, which says that people who become addicted are people who are morally weak, who can't say no. Up to now, this model is actual, because people are sent to prison to start thinking about their lives and to improve their life. In States, for instance, young people are sent on boot camps just to reconsider their lives and to recover from this moral weakness, let's say. The pharmacological model, which says that the problem, the weakness is situated like in the drug, that some drugs are very addictive and therefore they should be banned. For instance, the prohibition movement in the United States, which caused a total prohibition between 1920 and beginning of the 1930s, total ban on alcohol. Actually, there was not used more alcohol, I think, in the States than during that period, but that's something else. So this pharmacological model is another approach of addiction. The symptomatic model, and I think that's still an important model up to today, says that people become addicted because they often suffer from underlying psychological problems. So they may have suffered, they may have been beaten up by their fathers during their childhood. They come from emotionally weak environment. So the addiction is really a symptom of an underlying disorder. And from this approach, psychotherapy will be very important in order to help people to come over like these difficulties. Then you see 2 models which have ended, fortunately. The disease model, this is a model and it's still actual, and it comes back into the most modern brain disease model, but the old disease model said that actually we could divide this room into 2 groups. I know it's not like that, but so there is one part of the room who can use alcohol, and there is one who can't, because this side of the room has an inherited weakness for alcohol use, and that is why when they will start using drugs or alcohol, they will become dependent. So that's why, for instance, the AA says once an addict, once an alcohol abuser, always an alcohol abuser. So, but this underlying weakness comes back in the most modern, and actually the model that is used also in prevention, in treatment models, this new brain disease model, which has been extended and to incorporate, for instance, also aspects from the symptomatic model or from the biosocial model. Behaviors model, just be very short on that. It's people learn to use alcohol or drugs, for instance, to cope with their problems. So they have learned to use alcohol in terms they feel stressed, or at times better they feel stressed. So this is a kind of operant conditioning and behavioral model. And then the biopsychosocial model, it has added to the biological component, and that some people may have an inherited weakness, and that there is also some substances that are more addictive than others. The psychological aspect of the underlying symptomatology, and then the social aspect, which is very important. The neighborhood where you have been growing up, if you come from a very poor, deprivated neighborhood, this will also increase the chance that you become addicted, as well as, of course, your family environment, the way your parents have been coping with alcohol or drugs, whether they were drug users or alcohol users themselves. So actually we have a brain disease model to approach addiction, and this brain disease model actually says that there is indeed inherited vulnerability which can be found in many people, and it works as follows. Okay, so some people have inborn, it was not well translated, it's rather inherited vulnerability, which is the basis. And some people, some young people have, when they start using drugs, they will be more likely to continue using, because they have like an inherited brain damage, which worsens, which become worse when they repeat and when they continue using drugs. So it leads to brain changes, which can be still altered, but these brain changes make that you are even more vulnerable for further using drugs in the future. Craving, so in Dutch there is it was elected as the most nice word I think a couple of years ago, goesting. I think it's the best translation of the term craving. So a real strong desire for using drugs, which plays a central role and which will be very important, for instance, to address also during treatment. So now we have like the evidence that addiction is a often chronic, relapsing disorder, but recovery, and people can recover. There is enough examples that people can abstain from drugs, can rebuild their lives, can recover from drugs, but it is not so easy, and there is a lot of people who relapse. I think this is not so easy to see, but I'll just go over it briefly because it comes back in the next slides. So actually, when we talk about intervention and helping people with addiction problems, we should have a focus from the very beginning, the moment people have not used any drugs, till like supporting people who stopped using drugs during treatment to abstain from drugs and to recover from it. So when there is like 4 concepts we will distinguish here. There is prevention, 3 different forms I'll explain directly. Then we have early intervention for people who already start using, who have been in touch with these substances. Then there is treatment, and then there is continuing care, because as addiction is often relapsing, chronic disorder, we need to support these people over longer periods of time. And I think recovered users, we use them a lot in prevention activities, but we don't use them so often in treatment, only in like drug-free therapeutic communities. They are often used. In continuing care, in aftercare, where there is very few support, actually very few policy and government means go to the resources, don't go to aftercare. Well, I will show this is really the most important part of treatment and of keeping the gains, the benefits you have realized during treatment. So during prevention, you can distinguish between universal, selective and indicated prevention. Universal is, like the word says, for everybody, like in schools, for all kids above the age of 14 or above the age of 16. And then selective prevention is for at-risk groups. So we know, for instance, that in some types of secondary schools there is more use of drugs. And, for instance, children of addicted parents are also more are more vulnerable to substance use. So you direct your prevention efforts to this typical population. Indicated prevention, it's already early intervention, because this is really meant for people who already were in touch with the substance, so who started already using cannabis, who have been in touch with this kind of drugs. And for this population, it's very important also to early intervene in the process of addiction, so they do not end up in the addiction phase. So this is again the same. So for the whole group, directed at risk vulnerable groups, and then for vulnerable individuals, mostly people who have already been in touch with the substance. Here you also see how this relates with treatment. So we already discussed this first part, but early intervention is really starting, for instance, with people who have been in touch with the police because of they were held with drug possession, cannabis or another drug. So for these people, early intervention, some groups in which they start to reflect and to empower people to say no, for instance, to these drugs. And these are important efforts, and for people who continue on the way to addiction, treatment will be very important. So, an example of early intervention, it was already shown also in the video message, and you were, I think, already aware of the program Unplugged. So this is a very important program, and it's at the universal prevention side. A next stage is like to adapt these kind of interventions for specific groups who are at risk, like I said, the children of alcohol and drug addicts. And this is really a very underestimated problem. For instance, in the United Kingdom, there they see that their drug policy has failed like the last 20-30 years, because they are encountered not only with like generations, but like with 3 generations of drug addicts, where the grandfather was, for instance, an alcohol addict, father a drug addict, and the son of 17, 18 years old becomes a heroin addict. So these are very, very sad stories, and which we have in fact not promoted but stimulated with the policy we have been performing, because the policy, especially in the UK, like the last, not the last 5 years, but the 20 years before, was really on giving people who were addicted to heroin, because that was the main problem there, giving them methadone or other substitute drugs. So these people, they are so, they see drug use, and methadone, we know all about accidents with methadone. It's a lethal product, so if a child takes this, you die immediately. So we should be very careful about giving this. And also in the UK, methadone treatment has been described as methadone filling stations, like in a petrol station where you just go and take some petrol, some methadone in this case. And you should be very aware of giving this, and it should be also more selected. So therefore, in the UK, I will tell that later, but it pops up now during this presentation, they have shifted the focus to recovery, to promoting people not to depict a lifelong methadone use, for instance, but that recovery is possible and feasible for many people. And there is some nice examples of how you can reach that. So the indicated prevention is then more on really people's or pupils, for instance, who are very impulsive, who want to take a lot of risks, and who will end up easily using drugs. So coping skills regarding impulsivity, for instance, is very important in this area. But then, of course, in this whole story, because it's not because, of course, your father was an alcoholic or a drug addict that you will become a drug addict. So we should be very aware that although these people may have a higher risk of becoming addicted themselves, there is a high risk of stigmatization. So we should find a good balance between prevention and not stigmatizing people. Good. So for prevention, I've already made an outline of the different forms of prevention. Regarding treatment, we usually distinguish between outpatient drug-free treatment, so this is kind of counseling where people go to a mental health worker who talks with them and during 10 or 15 sessions. We have substitution treatment, which I already referred to, methadone treatment, so people are given a replacement drug instead of the more addictive drug they usually use. And then harm reduction services, well, harm reduction encompasses the substitution treatment, but it's also about needle exchange and giving people proper equipment, safe equipment to use their drugs. And then more on the other side, you have the drug-free oriented services, detox, residential rehabilitation in psychiatric hospitals, in treatment centers. And very important and often forgotten, or it's thought to be very important, but there should be more stress on this, is aftercare and continuing care. Good. I will take you now into a paradox which was raised a couple of years ago by one of the most important American researchers, Thomas McClellan, who challenged the way we have always looked at addiction treatment. Have we evaluated addiction treatment correctly? So I think if you look at addiction treatment, I think you all know that the compliance with treatment, and people tend to drop out quite quickly from treatment, relapse rates are high. He has challenged this statement by showing in fact that these rates of compliance, these rates of relapse are as high as among other disorders like diabetes, like hypertension, where we also see, and these figures I give here, they are for addiction populations, but in fact they are as high for people with diabetes and for people with hypertension. But we always say addicted people, they relapse quickly, they do not comply with treatment. So less than 50% of the addicted people take their medication according to the prescribed regime, the regime prescribed by the doctor, for instance. Less than 30% follows behavioral guidelines, following a diet. Within 1 year after starting treatment, 40 to 60% is taken up in treatment again, whether it is outpatient or inpatient, but start treatment again. And after the first treatment, there is usually no remission. So remission being the phase that people are no longer experiencing the symptoms, but they are not already cured. So for addiction, we know this, but it's probably more harder to believe that this is also the case, and these dropout rates, for instance, are as high for people with diabetes and hypertension. So still recovery is possible even without treatment, so I think that's also something important to say. People can take up their lives again, and this can happen through a sudden life event, and for instance the death of a very significant close other person. It can be because people start doing something different, a new job or whatever. So but people can recover even without treatment. I think that's important. And the remission phase, so the phase where the symptoms are going away, let's say, this is always a long period. So the next slide, I would like to ask you, I guess many of you, or at least some of you, are medical doctors, but I would like to ask it to everyone. If you go to a hospital, for instance, and you have quite severe problems when you enter the hospital, and when you are under treatment, your symptoms go down from like severity of 8 to only 2. And after 6 months, the treatment stops and your symptoms go up again. Who would say that this treatment was successful? Nobody? Okay, still, the next slide. When it comes to the treatment of hypertension, diabetes, for instance, insulin therapy, we know that people enter with a high problem severity when they meet first the doctor, and when they are given the therapy, their symptoms go down quickly. But we all know that people have to continue using the medication, otherwise the treatment will, the problems will go up again. So in this case, I think it seems fairly normal that if people do not comply with their insulin therapy, for instance, that they will have higher problems again. On the other hand, when we look to substance or addiction treatment, we say treatment has failed if people have again drug use or criminal involvement after treatment. And of course, there is something to say about that, but still, we think, and that's the challenge McClellan wants to make, we think that by putting people through treatment, that their symptoms will be over. And so, addiction has been, most of the time, been treated as an acute condition, while it's rather a chronic condition which needs continuing care. So it's not realistic to expect that the symptoms will stay low or as low after treatment. Although, for instance, in therapeutic communities, the treatment has been evaluated 2 years, 5 years after the treatment stopped. And yeah, we see, of course, that many people relapse, that 20 to 40% stay sober. But this is not considered to be a big success, because only 20% or only 40% stays abstinent. Good. Should we then conclude that prevention treatment have failed because many people start using drugs anyway? Many people relapse after drug treatment anyway? I don't think that's a good idea. We should be realistic about our expectations and also about the real treatment outcomes. So what we know is that there is a very strong correlation between treatment dosage, treatment length, and outcomes. This means that the longer you can keep people in treatment, the better they will do afterwards. And this counts for outpatient as well as for inpatient treatment. And of course, it's also for prevention that this counts to a large extent. The better and the more comprehensive your prevention program, and also the better the outcomes will be. Selection processes play, I won't say much about this, but motivation and yeah, reaching people at the right moment, that's very important for being able to change behavior. Like I said, this figure, less than 3% was abstinent. So in the UK they have done a study, a big study, in which they looked at people who followed different kinds of treatments. So some people followed methadone treatment, other people followed detoxification, other people followed long-term residential treatment. But of the people who were in substitution treatment, after 5 years they started this treatment, less than 3% was abstinent from heroin and other substances. So what this data say is that if we people substitution treatment, heroin or methadone treatment on a large scale, I think it doesn't lead to recovery. So therefore we need recovery, and especially because we see as I already said, transgenerational cycles of addiction and deprivation. So mothers, grandparents, children, grandchildren who become also addicted. The costs do not outweigh the benefits of treatment. So there is clear benefits of treatment in terms of crime reduction, economic participation, social participation, social inclusion. So this is very important to keep on, like also Wolfgang Goetze said, to further invest in treatment, in prevention activities. And here I have a very important finding from psychotherapy research. Although you're not psychologists, I assume, you know that there is various directions in psychotherapy. There is psychoanalysis and the couch where people have to lie on to tell their problems. There is behavioral therapy, system therapy, and so on. But research about this psychotherapy has shown that the therapeutic alliance, so the bond, the contact, the relation you have with your counselor, with your psychotherapist, with your psychologist, is much more important than the direction you follow. So whether it's psychoanalysis or whether it's behavioral therapy. So this identification with the counselor is found to be the best predictor of the outcomes also of such a therapeutic relation. So therefore, I think it's very important, and it's really a pledge to involve recovered users, because they are really identification models. They are role models which can help people also to recover from their drug use. Participation in AA aftercare, after treatment, is very important to keep the changes that they have reached. And also continuing formal and informal support. So formal support, I mean treatment, but informal support from the family, from the larger community, the neighborhood, is also very important in this. So there is really need for a recovery approach. Good, I will skip this because otherwise I won't be in time. How much time do we still have? 5 minutes or so? Yes. Yeah. Addiction recovery is increasingly studied. So what we mean by recovery is the establishment of a fulfilling, meaningful life and a positive sense of identity. So before we looked at recovery as something you should achieve, and you should achieve it through abstinence. Now we say it's much more important for people to have a meaningful life, having to do something in life, having to have something to live for, like a family, like a kind of leisure activity, a hobby which you like a lot, and also to have, this is the lifestyle change, changing your lifestyle, your drug using lifestyle, into also a more positive sense of identity, to be proud of yourself, to have a higher self-esteem, and to have a better positive sense of identity. So this is also coming not only in mental health research, but in addiction research. And we can reach that through different pathways. So it's about personal growth, it's not limited to substance use. So abstinence can be seen as one defining element of recovery, not as the defining element. So this means that recovery, people can also be still using, for instance, methadone on low levels, but it's about their social participation, it's about their participation in life as a whole. So recovery without abstinence is possible. It will usually require abstinence, but still it is not possible without. Good. I'll just briefly go into this. There is different dimensions of recovery. This is more theoretical, but what I think is very important is that we should give more attention to personal recovery. So clinical recovery means abstinence of symptoms, like we saw in the slide with the diagram. Personal recovery means that we make use of the lived experiences of individuals who have been through recovery. So people who have stopped the process of addiction themselves. And this is in fact something very important, because it's about self-confidence, it's about hope and empowerment in their lives. Recovery capital is crucial at important stages of the recovery continuum. So it's not only about the person. So in order to be able to recover, you will have some personal recovery capital, like personal characteristics and skills, people who have specific competences. For instance, people who are very good sellers, who are very good entrepreneurs. And this kind of specific competence can be used and can be very useful on the way to recovery, and we should use this. It's also about social recovery capital, the social network, the people around you, whether they support you and help you during your recovery journey. And finally, it's the community recovery capital and the extent of the support from the community, whether there is work available, whether there is help in the community where you can go for a chat if you need it, and so on. I will go now to my conclusions. So recovery, I think, requires more engagement in local communities. So we should use or make use of what we call recovery champions. So people who have been through recovery, who have been stable now for 2, 4, 6, 10 years. And these people, and there are many people around who have taken up their lives again, they can really mean a lot, and they can also help to shift the focus from traditional abstinence thinking and once an addict, always an addict, to more a recovery approach. So they can create hope and believe that recovery is possible. For instance, I think there is quite many famous people who have been through addiction themselves, and if you are able to engage these kind of people, it's a very strong, powerful means to this recovery movement. So how to engage recovered individual throughout the treatment continuum as a last question. There is some scientific evidence that these people can have an important role, although you have to be cautious, because these people have been through the problem themselves, so there is always the risk, of course, when they engage too much in the personal story, in the personal life of some others, that they will relapse, but you can also deal with this kind of problem. So we need to go to a recovery approach. So we need to do more than just providing substitute drugs. Treatment is not enough to recover, because often ongoing support, so treatment is usually 6 months, 10 months, but especially the period afterwards to keep people doing what they have been doing through this treatment, to keep them from using drugs, and to also give them a meaningful role. And this meaningful role can be, of course, helping other people who experience the same problem as they have had. So I think we have very much capital there that we do not use, because there's many people out there. There is only a very small proportion of these people who start working in this addiction field, but there is many more who could have a contributing role. So it's about individuals, but also about surroundings, communities who suffer from addiction problems. So my final slide, which may be a bit of an inspiration for starting up a recovery movement in Belgium. Why should that be necessary? I think, and I say Belgium here, but there is in the UK, there is some work done already. In the rest of Europe, it's starting up, but not so much. So we really need an impetus there. So it's very important to raise awareness that recovery is possible. It can be sensibilization through media, community activities, through famous recovered persons, for instance, organization of events. So in the UK, for instance, each year there is a recovery walk that is organized, so it's a big walk with 5,000 or 10,000 participants, and that also raise the awareness, all people who are in recovery, their families, their other people who have sympathy with them, and so on. To recruit recovery champions, so these are the people who have been or who are in recovery for many years and who can help and who can support peers in various stages of the addiction process, whether it be prevention, treatment, and also very important in the continuing care phase. I think it's important to say that treatment can be crucial to recover, but it's not only about treatment, it's also about recovery, and it's about the necessary resources among you. It's also important to raise the voice and to advocate for the rights and the social position of substance users in society, and to prevent, of course, this kind of substance use problems. And finally, and probably there will be talk to, again, a recovery-oriented approach. So that's what I wanted to tell to you. Thank you.